Hi. I haven't met a lot of you yet, so I usually have a bunch of slides. I thought I was going to do this tomorrow and my actual presentation today. So my name is Dave Shirazi. I'm a dentist. I'm an acupuncturist. I'm a sleep technologist, and my practice is limited to pain, sleep, and functional orthodontics. So this is a case study of a guy that came in with a chief complaint of headache, neck pain, shoulder pain, and not feeling refreshed in the morning. Let me see. Charles, which one is the there you go. There's the laser pointer. Great. Fantastic. That is not him, by the way. Charles put this in because he thought it was too dull without it. So he had a range of motion of 44 millimeters. Okay, so you guys are probably wondering what normal range of motion is. There's only been one proper study that's actually observed norms of what normal range of motion is, and it's different for facial types, right? So dolichocephalic, which is what we call a narrow face, kind of like the mouth breather kind of face, a minimum of 42 millimeters is considered normal for them. Mesiocephalic face, which is sort of like a medium, sort of roundish sort of face, 48 is millimeter. He was mesocephalic. And brachycephalic, these are the white, broad face people. I'm actually broad face, but I'm so fat, it kind of covers in the chiseled part, so you can't see how handsome I am. So, and they start at 52 and up. So you have to understand the range of motion of the norm varies per facial type. And that's because the more widely developed their skulls are, their palates are, the slope of the temporal eminence changes. So when they're dolichocephalic, the temporal eminence is very, very steep, almost vertical, and they cannot translate that well. As they become wider in the face, it becomes flatter, and they're able to translate longer. Does that make sense? Please ask me any questions if it doesn't make sense. Yeah. I think it's closer to the end. It's in one of the books. It should be in that one, actually. But you won't see this picture, okay? He deviated to the right, deflected to the left. Okay, so deviation means as you open, which direction you start to go. Deflection means where you end up, right? And when you have a deflection, that's a disc displacement without reduction and or arthritis. And or arthritis, okay? Headache, which is chief complaint, neck pain, shoulder pain, bruxism, nasal obstruction, not feeling refreshed in the morning, osteopenia, asthma, and history of sinus issues. So he tested motor reflex as a TMJ primary, which means it was a descending pattern. Neurologically speaking, in the moment that I saw him, he tested as TMJ primary, right? So that's something there's 4 scientific validation studies for the motor reflex test. It's not a muscle test. It looks like a muscle test. I acknowledge that it looks like a muscle test, but it's more like a patellar tendon or a Babinski. It's not a muscle test, okay? So my suggested treatment strategy was a day repositioning orthotic, a night anterior deprogramming orthotic, which also holds the lower mandible. I'll get to that in just a moment. Referral for nasal ballooning, because I saw something on the CT, which I'm going to show you. SOT referral and prolotherapy. So this was his lateral ceph. You can see the subluxations of the spine. So I don't, just so you guys know, I don't know if you've been to a lot of dental lectures. Because airway is a hot topic now for general dentists, they're always showing pictures of the size of the airway, the diameter, the 3-dimensional volumetric rendering, as if that's somehow diagnostic of sleep apnea and sleep disorders. It is not, okay? It is just a volume rendering of the airway size. Granted, if you have a larger size to start with, you will end up with less likelihood of having sleep apnea. But in no way does it tell you how many times you're getting apneic events, if you have nasal resistance that causes mouth breathing or not. So I just do this to kind of show you chiropractors what the cervical spine looks like. And I look at TMJ as C0, as the next cervical vertebra above C1. And I even tell my patients the same thing. Okay? You can kind of see in the AP, you can kind of see how off-centered the spine is from where it sits. These are the condyles, the right and left. You can kind of see it's more focused in the fossa. You can see how it's even more retruded here. This is the side that has the disc displacement without reduction. You can't see discs very well on CT, but his disc would be about right there. Actually, you can kind of see it. Do you kind of see a little hint of it? So that means if this was a disc displacement with reduction, as they rotate and translate forward, right when they get underneath it, you'd hear a click or a pop, and it would pop right back on, right? Because it doesn't, it's very quiet like a normal joint, but as you try to translate, it's going to be stuck, so they're going to deflect to that side. Does that make sense? Okay. We did a home sleep study. I have a full sleep lab where we can do full overnight studies and home sleep studies. When I see evidence of bruxism, like clenching of their teeth, depending on which study you look at, 50 to 60% of the time, the reason why we clench our teeth is because of sleep apnea or what's called upper airway resistance. So all my patients, I always want to screen for that and see if that's the cause. If it is, I'm going to address it. Mouth breathing, obviously they're mouth breathing because they can't breathe through their nose. All my orthotics need to allow for free movement of the mandible. I do not agree with either a day or night orthotic locking the jaws in together, because if they brux, it's going to cause a problem in the joint. Even if it holds the joints in ideal jaw position, by forcing while they're bruxing and they're rigidly in place, you will still exsanguinate all the synovial fluid out of the joint. I want to be able to glide at nighttime. I want to be able to glide the condyles into centric relation, and then once they get there, I want to be able to reduce their muscle firing 50 to 100%. I never promise anybody that I'm going to stop them from clenching their teeth for the rest of their lives. Okay? There are so many reasons why we clench our teeth. We're still learning every week, it seems, of another reason why we clench our teeth, right? Your spouse could upset you. Someone could cut you off on the freeway. You can go clench your teeth. If you're a type A personality, you're more inclined. So I don't even pretend to promise them that. So this was what his sleep study presented as. So for an adult white male, which is what he was, it was in his 40s, 5 episodes or less per hour. And then what I mean by episodes is either apneas or hypopnea. So an apnea is when you have a cessation of airflow, like it's shut off for 10 seconds or greater. Okay, that's one apnea. A hypopnea is shallow breathing, like that causes significant oxygen desaturation. Okay, and then we divide that, we get an average per hour. 5 or less is within normal limits. It's much different for a child and different for females. 5 to 15 is mild, 15 to 30 is moderate, anything over 30 is severe. So he's at 7, he's relatively mild. His oxygen drops down to 86. For a nadir, 91 is normal. So 86 is 5 points below that. So with his daytime orthotic, that's his jaw position. So you saw Richard's video this morning of me having them count from 66 to 77. The phonetic position is the only position that I know of that only in the rare cases of severe internal derangement will put both condyles in centric relation. And the reason I say both condyles, you saw from the previous slide that this condyle was way more off than the right. And you can see there's more correction on the right too with this phonetic, but it's a very unusual thing when you have a 3-dimensional structure that is one in this direction that typically goes, it rotates, it translates, it has a different height relationship, to just get another bite, another jaw position that satisfies both sides at the same time, and they're able to chew food with it and speak and not sound like this when they're doing it. It's very challenging. Any questions yet? Yes. Later? Later? I'm sorry. Okay. So, so the phase 2 was nasal ballooning by Dr. Adam Del Torto. He's the guy that teaches everybody, how to do it, right, Charles? Yeah. So we could see the severe deviation in his septum. The mucosal lining of the terminates engorges during supine sleep, and it has that cycle one side over the other, so that makes the obstruction even worse. I made my own nasal spray with essential oils a couple years ago, and I'm getting really, really good success with it. It even cleans up the biofilm and astringes the tissue. So this is, and you all know what the nasal ballooning is, right? He takes a deflated balloon inside the nose and then expands it rapidly. So this is what the turbinates look like here, with the development here on the right inferior turbinate. You can see the difference here. That makes sense? You guys can see the difference? Here it is in subventral vertex view. You can see here the constriction here, the opening there, clearly the opening here, and the opening there. Yeah. So just as a reference point, before the Industrial Revolution, when everyone was breastfed up to 5 years of age, chewed food as soon as they had teeth, and had nothing watered down for them, this is what a prehistoric skull looked like. This was their turbinate space, and this was their sinus space. This was normal. How shocking is that picture? Okay? Like an ENT would look at this picture and say that was normal. And you can clearly see that's pretty constricted here. Yeah? Makes sense? Okay? So for Faith 3, I refer to Richard, and he may want to chime in on some of these slides, because I only use the jargon in a superficial fashion when I speak to chiropractors. I don't pretend to know as much as Charles and Richard do. But because motor reflex testing was shown that it was a descending pattern after the orthotics, I send them over to Richard or Charles. I only work with SOT chiros. If the patient doesn't want to go to an SOT chiro, I won't work with them. Because if they get a conventional adjustment, or what do you call it, the activator, or some other kind of style, or sports chiropractic style, that's like a disaster waiting to happen. Okay. So there it is. So this is your guys' language, right? SOT indicators found in unstable musculoskeletal system leading to overcompensation with ligament laxity. Category 2. I think you did use a belt on him, right? Yeah. Myofascial restriction in the TMJ muscles, masseter pterygoids and temporalis. Do you want to say anything about this, like what you did?
Yeah. So this is just basically the standard stuff I was showing you. There's no real difference. The only thing that was different here was the cervical compaction test was positive. So that is your indicator for a cervical major that had to be released, which can be released as passive or active manual manipulation. I think with him I did passive until I got the cervical to unlock, but that was the only different about this. Rest of it's just standard category 2 treatment.
All right. We'll talk about releasing cranial sutures.
Right. So this is just the normal protocol getting into the TMJ and into the clenching pattern and the headaches related to that. So there's nothing abnormal with that.
So he got me all set up for prolotherapy. He's my human MRI. Charles is my human MRI. They'll palpate and they'll say, he's ready for prolo. I moved it into position, but it won't stay. The ligament just is too stretched out.
Or it won't move into position.
Or it won't move into position, and we need to clear up the scar tissue. So then we'll do prolotherapy, usually in the posterior joint space. That was a case with him. So, and just so you all understand, the daytime orthotic is used to hold the centric relation during the 2,000 to 3,000 swallows we have per day, when we speak, when we chew, and it's only for 3 months. There are actually laws in place for dentists that if they make a 24-hour appliance, and of course I have 2 appliances, that counts as 24 hours, that there has to be a weaning, whether they're ready or not, at the 10 to 12 week mark. There has to be, right? If the patient refuses or says, okay, I did it, I didn't like it, I put it back in, that's fine. But just to cover our butts, we need to do that. Because, and by the way, if you guys adjust the patient and their bite changes, no problem. If we change their bite, it's like a spotlight, right? So we did prolotherapy, and you understand prolotherapy strengthens and tightens ligaments, and helps the condyle seat, helps the disc seat more permanently into the condyle. So this is and he's not even totally finished. Everything resolved 100% except for his headaches. His headaches are very kind of touch and go. He went a month without a headache, and then now they're sort of coming back. So we're working on the gallbladder, as you believe we said.
We're now into his stress pattern, kind of the emotional, psychological part of it, and that he has a cycle to the headaches that's it's ended up being a gallbladder reflex related.
At 4 o'clock in the morning, that's when he gets his headaches only.
Right.
And almost always on a Friday.
And it's the end of the,
really
it's the end of the work week.
Yeah.
So
Not for him. He works during the weekend.
Right.
Yeah. Maybe in the middle or in the beginning of the work week.
That's right for him. Yeah. Okay.
Okay. Charles is kicking me off the stage. I just want to show you the ending or near ending images. So thank you guys.
Thank you.